Welcome. Good morning, good afternoon, good evening. Welcome, everybody, to today's virtual launch of the WHO Guideline on the Prevention, Diagnosis, and Treatment of Infertility. My name is Nandita Tate. I'm a technical officer here at WHO, and we are delighted to be hosting this event with all of you. A few quick logistics notes. We have a very full session today. This session is being recorded and will be posted in the coming days on the WHO HRP Media YouTube channel. The session today will be in English, but we do have French and Spanish interpretation. So please select your preferred language. You can use the icon at the bottom of your screen to select the channel you prefer. Finally, we encourage you to submit your questions using the Q&A box also at the bottom of the screen, and use the chat to introduce yourselves, share any comments, how you might use the guidelines, and really allow for some dialogue. We have over 2,000 people registered from about 125 countries, so we are delighted to have you all with us today for this very important topic. Really quickly, today's agenda will be as follows. We're going to hear some brief remarks from the director of our department at WHO, as well as the chair of the Guideline Development Group. We'll then hear a summary of the methods used to develop the guideline, and then we'll hear some presentations on the recommendations by the various Guideline Development Group topic leads. We'll then hear from a patient advocate, and then some remarks from our vice chair, some Q&A, and then some next steps. So with that, I'm going to introduce the director of the Department of Sexual, Reproductive, Maternal, Adolescent, and Child Health, Dr. Pascale Alloté. She unfortunately could not join us live for today's event, but has sent a video with some remarks. So I will play that for you now.
Colleagues,
Oops.
partners, and friends. Infertility has gained unprecedented political and public attention in recent years. The release of WHO's global estimates of infertility prevalence, showing that 1 in 6 people will experience infertility during their lifetime, has renewed recognition that this is not a rare condition affecting a small subset of the population. It affects individuals and couples in every region, at every income level, and across every social group. At the same time, global anxieties over declining fertility rates have fueled new debates about demographic futures. These discussions, while important, are often conflated with infertility in ways that risk obscuring the underlying drivers, the distinct causal pathways, and the diverse experiences of those who are directly affected. But today, our focus is clear. We are here to address a critical and long-neglected piece of this complex puzzle, ensuring that fertility care, which includes services to prevent, diagnose, and treat infertility, is safe, effective, fair, and grounded in the principles of human rights and equity. Until now, countries, clinicians, patient groups, and partners have lacked a unified evidence-based reference from WHO to guide the provision of infertility care. This new guideline fills that gap. It brings together a rigorous body of evidence to support the prevention, diagnosis, and treatment of infertility, covering male, female, and unexplained infertility in a single comprehensive resource. It responds directly to requests from member states for clarity, consistency, and normative direction. The guideline builds on WHO's recent efforts to strengthen the availability of essential medicines and diagnostic tests for fertility care, including their inclusion in the model lists, a critical step in ensuring that people can access services without financial catastrophe. And it reinforces the broader mandate of WHO, that sexual and reproductive health, including fertility care, is an integral part of universal health coverage. The recommendations set out a coherent pathway for countries to adopt, adapt, and update their national clinical guidance. They highlight the need for implementation that reflects local context while adhering to global standards of quality, equity, and rights. Successful implementation will require collaboration. Ministries of health, professional societies, civil society, and importantly, the people and communities most affected by infertility. This guideline makes a clear statement. Infertility services should be available at primary care level, embedded in financing and insurance packages, including in universal health coverage, and delivered without discrimination and without forcing people into catastrophic expenditure. For too long, infertility services have been among the most inequitable components of reproductive health care. Today, we begin to change that. Importantly, these recommendations are anchored in a comprehensive, rights-based approach to sexual and reproductive health. Fertility care must empower individuals to make informed decisions about whether and when to have children. It must be grounded in gender equality, bodily autonomy, and respect for the dignity of all people. This guideline is just the beginning. It acknowledges gaps in the evidence and highlights areas for further research. It signals WHO's commitment and the commitment of HRP to advance the science, build stronger health systems, and support countries as they work to ensure that fertility care becomes a core component of universal health coverage. I am confident that what we initiate today will transform how infertility is understood, addressed, and prioritized globally. Thank you for your commitment and partnership, and I wish you an engaging and thought-provoking webinar. And I hope you leave today not only informed, but inspired to go deeper, ask more questions, and join us in advancing this critical area of sexual and reproductive health.
Super. Thank you, Dr. Pascal, for your continued support and your inspiring remarks. It is now my pleasure to introduce the chair of the Guideline Development Group, Professor Richard Kennedy. Professor, you have the floor. Welcome.
Thank you and good day, everybody. It's a great pleasure and privilege to be able to take part in this launch today and make some introductory comments. Today's launch marks the completion of work that began about 7 years ago pre-pandemic. It represents a major milestone in the worldwide treatment of infertility, providing as it does for the first time WHO guidance for the management of the millions of men and women who suffer from infertility. The approach to the development of this guideline has been evidence-based. The process has been robust and rigorous and has strictly followed the WHO procedures for guideline development. The 40 recommendations in the guideline, which will be covered in the next few presentations, cover the prevention as well as diagnosis and treatment of male and female infertility, and as you will see, reflect contemporary practice. In addition to the guidance and the evidence-based recommendations, there are a number of pragmatic and applicable good practice statements. We know that the burden of infertility disease is significant, with a global lifetime prevalence of 17.9%, and that there is a substantial gap between the need for and utilization of infertility services globally. We know also that cost is a major barrier to men and women being able to access care. Our belief is that adoption of this guideline will pave the way to improving access to affordable care, and we therefore call upon all clinicians, professional societies and ministries to support its implementation, and for health ministries and those that commission healthcare to use this framework to develop their services. I would like to acknowledge my co-chair, Cindy Farker, all members of the Guideline Development Group, in particular, the diligent and time-consuming work undertaken by the topic leads who have stuck to the task and remained true to the principles of producing an evidence-based guideline. I'd also like to acknowledge the work of the McMaster team, whose rigorous synthesis of the evidence has underpinned the project. I'd also like to thank the external review group for their extremely helpful feedback on the draft guidelines. And finally, I'd like to acknowledge the HRP team at WHO, especially Gitau Maburu, whose tenacity and energy has been instrumental in driving this project across the finishing line. So without further ado, I will now pass you over to Gitau Maburu, who will talk through in more detail about the methodological approach. And after Gitau, we'll hear from the topic leads who will provide more details on the guideline recommendations. Thank you all.
Thank you very much, Richard, for that introduction. I will cover burden, methods, and approach used for the development of the guideline, and thank all participants for joining this webinar. Next slide, please. The burden of infertility is very clear. Approximately 1 in 6 people of reproductive age experience infertility at some stage in their life. And we also know that infertility can be caused by male, female, or unexplained factors, sometimes a combination of both male and female factors. In a large WHO multi-country study that was conducted in 25 countries, 30% of infertility cases were due to female factors, 26.3% was due to male and female factors. Male factors alone contributed to 18.7% of infertility cases, and in 10.8% the causes were undetermined. As the previous speaker has mentioned, the most recent data we have is that 17.5% is the prevalence of infertility across the lifetime, but at any one time, this prevalence is 12.6%. As you'll all agree with me, the lifetime prevalence is a much more and better measure of burden of infertility because infertility can happen at any time during reproductive life years. An important point to also make is that there is no significant difference between high-income countries and low-income countries in terms of prevalence. Next. Next, please. An additional point that I would like to highlight in terms of context and impact of infertility is that infertility is not consistently included in health policy, services, and financing in many countries. Where it is included, financing of services and reimbursement is not always fully covered. In addition, in terms of the burden, we have data recently showing that 36% of women with infertility are exposed to intimate partner violence, which gives us an additional reason for us to think about the impact of infertility. People often incur large expenditures in terms of out-of-pocket costs to pay for treatment of infertility, sometimes up to 200% of GDP for a single cycle of IVF. We also have consistent and very significant evidence showing that infertility leads to poor mental health, particularly anxiety and depression, relationship problems, social stigma, most of the time disproportionately affecting women. Next, please. So we have many reasons to address infertility, not least because individuals and couples have the right to decide the number and spacing of their children. We also know that infertility can hinder the ability of people to achieve their fertility preferences. And this slide really shows you multiple reasons, and these are not all the reasons, but there are multiple reasons why we should be addressing infertility. Addressing infertility is central to gender equity and sustainable goal number 5. It is central to right to health and sustainable goal number 3. It is very central to the right to enjoy to enjoy the benefits of scientific progress and their applications, for example, in terms of IVF. And it is important for infertility to be included in primary healthcare, which forms the foundation of healthcare systems. At present time, this is not the case. Many people are spending money on IVF out of pocket, and we need to make sure that we are protecting people by enhancing financial protection and coverage for infertility services. Services for infertility should be equitable. It should be part of universal health coverage. Next, please. So in terms of the methods, we followed the WHO 2014 Handbook for Guideline Development, which lays out the procedures for development of guidelines. And what you can see on this slide are the key steps that we followed, starting with the establishment of a guideline development group in 2018, determining the scope of the guideline, identifying recommendation questions, retrieving and synthesizing evidence, which was then presented to the GDG for deliberation and formation of recommendations. And these recommendations were also reviewed by an external review group of 30 people from many different countries. And eventually we were able to get these guidelines approved most recently just this month. And we want to thank all the people who have participated in this development. Next, please. In terms of the scope and audience for this guideline, it is primarily a clinical guideline. It is intended for healthcare providers, but also it is useful for a number of other stakeholders. What you'll see on this slide is that the scope itself includes prevention, diagnosis, and treatment of infertility, and it is intended to improve standards of fertility care globally, and it is really relevant to a number of stakeholders, including professional societies, funding and philanthropic organizations, policymakers who are responsible for making national health policies in different countries. It is a useful resource for patient support and advocacy organizations. And as I mentioned before, we expect that it's going to be largely used by physicians, embryologists, nurses, midwives, laboratory specialists, and all other healthcare providers who are involved in provision of fertility care in many countries. Next slide, please. One of the critical points that the guideline makes is that it sets out the critical steps for the evaluation and management of infertility, and it provides these components right from initial consultation, taking and recording medical history and physical examination, conducting diagnostic evaluation, discussing the diagnosis of patients and people who are affected by infertility, providing relevant information, and referring people who have comorbidities or coexisting conditions that may have an impact on fertility, agreeing and providing treatment for infertility, providing follow-up consistently, and at the end of the process, documenting those outcomes. And these steps are then followed up. Yes, next please. And these steps are then supported by a number of good practice statements, which really should underline the approach to the evaluation management of infertility all over the world, because these are essential steps that every patient and every healthcare provider should think about in terms of quality of care. I will not read all these statements on the slide, but you can see they relate to the selection of tests, listening to couples and individuals, making treatment decisions, thinking about cost effectiveness of treatments, discussing the plan for follow-up, and documenting the outcomes. This is an important part of the guideline recommendations. I'll stop there now and hand over back to Dr. Nandita Thate. Thank you very much indeed.
Super. Thank you, Gitao. And for those online, we will be sharing a copy of the slides towards the end of the presentation. So you will be able to look in more detail. And the guideline and a summary of the recommendations are posted online. So we will put those links in the chat for you as well. I'm now going to turn it over to Professor Jackie Boivin, who will be presenting on behalf of the GDG on the prevention of infertility. Jackie, welcome. You have the floor.
Thank you very much. I'm very pleased and in fact honored to be presenting on behalf of the GDG on the prevention of infertility. The 4 areas of infertility that I'll present in are listed here, and I'll go into some detail now. So the WHO guidelines contain several recommendations for preventing infertility. Some recommendations are about the general population of reproductive age. Others are about individuals and couples with infertility. There are also recommendations for risk reduction from sexually transmitted infections, and also recommendations for risk reduction from smoking, from tobacco smoking. Next slide, thank you. For the recommendations, on information provisions for the general population reproductive age, WHO suggests providing information about fertility and infertility using low-cost strategies whenever there is an opportunity. Low-cost strategies might include, for example, information in digital or paper format when opportunities occur in schools, at primary healthcare centers, at reproductive health clinics. The information should be adapted to local context and audiences. Now, for couples with infertility, WHO suggests providing low-cost lifestyle advice before and during infertility treatment. By lifestyle advice, the lifestyle advice may include advice to change diet, alcohol intake, smoking, physical activity, or weight management. Next slide. In regards to recommendations for risk reduction from tobacco smoking, the WHO recommends that brief advice between 30 seconds and 3 minutes per encounter be consistently provided by healthcare providers as a routine practice to all tobacco users accessing healthcare settings. This is an existing WHO recommendation for the general population that also applies to couples who are planning a pregnancy, attempting to achieve a pregnancy, or those with infertility. And this is so because of the strong association between infertility and current or previous history of smoking. Brief advice to stop using tobacco usually only takes a few minutes and should be given to all tobacco users. Next slide. The WHO also recommends for smoking that brief advice between 30 seconds and 3 minutes per encounter be consistently provided by healthcare providers as a routine practice to all tobacco users accessing any healthcare settings. This is really brief advice about the risk of smoking, that the risk of smoking is associated with a higher risk of infertility, and vice versa. And also that a range of interventions to assist in cessation of tobacco use exists. All adults interested in quitting smoking should be offered or referred the interventions according to existing WHO guidelines. Next slide. For sexually transmitted infections, the recommendation is that couples and individuals planning or attempting to achieve pregnancy or who are accessing any healthcare setting should be routinely informed about sexually transmitted infections, including the risk of infertility when STIs are untreated. Couples and individuals should be encouraged to seek prompt care and treatment if they have symptoms. And if symptoms of an STI are present or infection is confirmed, the WHO guideline recommendations on management of STIs are available. Next slide.
Super.
Thank you very much.
Thank you very much, Jackie, for that overview. We are now going to move into a session on the diagnosis of infertility. And for this, it's going to be presented on behalf of the GDG by three professors, Professor Robert Rebar, Professor Sandro Estevez, and Professor Tan Su. And I will invite my colleagues to join and discuss the diagnosis of infertility. They will be focusing on female infertility, male fertility, and unexplained fertility. So I will turn it over to Professor Rebar to get us started. Welcome, Professor. You have the floor.
Thank you. Greetings to all from snowy Southwest Michigan, where it is now just after 7 o'clock. And I'm going to begin by talking about recommendations for a diagnosis of infertility due to ovulatory dysfunction. For females with infertility, but normal findings on history taking, the World Health Organization suggests presumptive confirmation of ovulation by measuring the level of serum progesterone rather than performing an ultrasound scan. And for those where the mid-luteal progesterone indicates no ovulation, it is suggested that this be repeated. I would like to call your attention to the fact that due to time constraints, I really don't have the time to talk about the remarks that are included on each of the slides that you will receive. And I would also like to note that many of these, in fact, virtually all, are conditional recommendations because of very low or low certainty of evidence. This is obviously because of the difficulties in performing randomized controlled studies in populations of infertile individuals and couples. Next slide, please. For females with infertility and suspected anovulation or oligoovulation, it is good practice to assess reproductive hormones in the hypothalamic pituitary ovarian axis. There are several hormones that can be assessed, and additional hormones should be ordered based on the findings in the history and the physical examination. This obviously is a good practice statement. Thank you. Next slide. For females with infertility in whom other causes of anovulation and oligoovulation have been ruled out, the World Health Organization suggests that a diagnosis of the ovarian reserve should be based on age rather than on diagnostic tests. Age still is the most important predictor of ovarian reserve. However, if ovarian reserve is determined, then the World Health Organization suggests using either antral follicle count, anti-Mullerian hormone, or day 2 or day 3 FSH because of the low certainty of evidence. Next slide, please. For females with infertility and tubal disease now that is suspected, the World Health Organization suggests that either hysterosalpingography or hysterosalpingo contrast sonography can be used to assess tubal patency, again, due to the low certainty of evidence. Next slide, please. For females with infertility who are suspected to have a uterine cavity disorder, the World Health Organization now suggests that the uterine cavity be assessed with saline infusion sonohysterography rather than three-dimensional ultrasound. Again, for individuals and females with infertility who are suspected to have a uterine cavity disorder, we are suggesting assessing the uterine cavity with three-dimensional ultrasound rather than two-dimensional ultrasound when the resources are available. And for females with infertility with suspected uterine cavity disorders, World Health Organization suggests assessing the uterine cavity with saline infusion sonohysterography, SIS, rather than two-dimensional ultrasound. Again, this is based on resources available. Next slide, please. For females who do have a suspected uterine cavity disorder, the World Health Organization suggests that the uterine cavity be assessed with saline infusion sonohysterography rather than with a hysterosalpingogram, understanding again that this is a conditional recommendation with very low certainty of evidence. Next slide. Based on these recommendations, we have developed an diagnostic algorithm for the assessment of the uterine cavity. Clearly, the choice of method is based on the resources available. Next slide, please. And again, we have developed a logarithm based on all the recommendations for female factor and unexplained factor infertility. It is impossible for me to go through this entire algorithm, but it will be available to you, and it is based on all of the recommendations in this guideline. Thank you. Next slide. Thank you so much.
Thank you, Bob. I'm also honored to present in this session, specifically talking about male infertility on behalf of the Guideline Development Group. So I want to start with the core recommendations that anchor the male diagnostic pathway. So the guideline positions semen analysis as the cornerstone laboratory test for initial evaluation and provides clear recommendations regarding repeat testing. So for males in couples with infertility, with one or more semen parameters outside the WHO reference ranges, the guideline suggests repeating the semen analysis after a minimum of 11 weeks to account for one spermatogenic cycle. And when all semen parameters fall within these ranges, the guideline suggests not repeating the semen analysis. So both recommendations are conditional with very low certainty of evidence. So importantly, adherence to the latest edition of the WHO Laboratory Manual for the Examination and Processing of Human Semen is emphasized because this manual, as we all know, provides reference ranges for semen parameters and also standardized procedures for semen collection and analysis. Next slide, please. So with that foundation, we move into the clinical pathway, essentially the journey each man takes through evaluation, and the guideline includes a diagnostic algorithm, which is designed to ensure that every man in an infertile couple receives a systematic evaluation. So the pathway begins with a comprehensive medical, reproductive, and sexual history, followed by a focused physical examination and a semen analysis. So findings from this triad are then integrated. So suppose reversible or treatable conditions, such as genital infections or modifiable lifestyle exposures, are identified. In that case, this should be addressed and then the patient reevaluated. However, persistent abnormalities or semen parameters outside the WHO reference ranges prompt referral to a clinician who has experience in treating male infertility. And when the male evaluation reveals no clinically significant abnormalities and semen analysis falls within reference ranges, the algorithm directs assessment toward the female partner, and only after appropriate evaluation of both partners can a diagnosis of unexplained infertility be made. Next, please. So behind that flow chart is real clinical work, and this panel shows what we systematically assess in the history and physical examination. On the history side, we explore systematic illnesses, childhood conditions such as cryptorchidism or testicular torsions, infections, oncologic treatments, exposure to gonadotoxins, medications, and lifestyle factors such as obesity, smoking, or anabolic steroid use. All of this is critical because many of these conditions are potentially reversible causes of impaired spermatogenesis. So the physical examination is equally important. We assess virilization, gynecomastia, penile anatomy, testicular size and consistency, epididymal and vasal structures, and scrotal findings, including varicocele. So together, the history, physical examination, and semen analysis create a structured and globally applicable pathway that ensures men are not overlooked and that preventable or treatable causes of infertility are identified early. So this algorithm is not designed to differentiate among the many causes of male infertility or to address molecular or functional sperm abnormalities. Instead, it provides a triage mechanism enabling non-specialists to manage straightforward issues while ensuring timely referral for complex conditions. Thank you.
I guess this is my turn. Without waiting for Nandita, I'm taking the word. Thank you, Sandro. Greetings from Istanbul. Up to this point of the webinar, you've already heard about the unexplained infertility at some forks along the diagnostic pathways of male and female infertility. I will now compile and summarize the information. WHO suggests making a diagnosis of unexplained infertility in a couple when all the following have occurred. The first condition is failure to achieve pregnancy after 12 months of regular, unprotected sexual intercourse. The word regular should be defined as not only frequent, but more importantly, its occurrence within the fertile window should be confirmed. The second condition is normal physical examination and medical history in both the male and female partners. I want to emphasize the word both. When an andrologist is not available, a gynecologist can perform physical examinations also in the male partner when needed. The third condition is presumptive confirmation of ovulation as indicated by mid-luteal progesterone and patent tubes as shown by either hysterosalpingography or hysterosalpingo-contrast sonography in the female partner. And finally, the fourth condition is semen parameters that are within the WHO reference ranges in the male partner. The procedures for the examination and for processing of human semen are detailed in the WHO semen manuals. Thank you. Handing back to you, Nandita.
Super. Thank you all for that excellent presentation, really looking at the diagnosis of infertility. And we are now going to move to the next part of the session where we are going to be talking about treatment for infertility. And I would like to introduce on behalf of the GDG, Professor Adam Balin, Professor Sandro Esteves, and Professor Tansu. And again, this session will be organized around treatment of female infertility, treatment of male infertility, and then recommendations for unexplained infertility. Over to you. Welcome, Dr. Balin.
Thank you so much. It's a great honor to be presenting on behalf of the Guideline Development Group our recommendations for the treatment of infertility due to ovulatory dysfunction. I need to be brief because of time. For those with infertility due to ovulatory dysfunction caused by polycystic ovary syndrome, the WHO suggests using letrozole as first-line treatment rather than clomiphene or metformin. However, where off-label use of letrozole is not permitted, clomiphene citrate should be used combined with metformin rather than clomiphene citrate alone. And of course, we provide detailed background evidence for this. Key also, as part of the management of PCOS, it is good practice to advise patients on lifestyle interventions, including healthy diet, regular physical activity, and weight management. Next, please. For those with anovulatory PCOS who have not been successful with oral letrozole or clomiphene, the Guideline Development Group recommends the use of injectable gonadotrophins rather than laparoscopic ovarian drilling. And when pharmacological therapy has failed, the Guideline Development Group suggests IVF rather than expectant management. Last, for a separate subgroup, those with ovulatory dysfunction caused by hyperprolactinemia, the WHO suggests using cabergoline rather than bromocriptine as treatment. Next. So this is the algorithm for the management of PCOS, which is available with all the background evidence. I don't have time to read through this in detail. Next slide, please. The recommendations for the treatment of infertility due to tubal disease really are based upon age. So for those who are under the age of 35 with mild to moderate tubal disease, surgery is suggested rather than moving straight to IVF, whereas if there is more severe tubal disease, the WHO suggests IVF rather than surgery. Next slide, please. When over the age of 35 with any tubal disease, the WHO suggests IVF rather than surgery. And if there is a hydrosalpinx, the WHO suggests either salpingectomy or tubal occlusion before the provision of IVF. Next slide, please. Last, for uterine cavity disorder, and again there's a lot of background evidence presented in the guideline, the WHO suggests that hysteroscopic septum resection, in other words, septoplasty, is not recommended. Thank you.
Okay, let me now turn to treatment recommendations for males, beginning with antioxidants. This is an area of high interest for both clinicians and patients, and the guideline addresses it very clearly. So it says, for males with infertility and one or more semen parameters that are outside the WHO reference ranges, who are attempting to achieve pregnancy with or without medically assisted reproduction, the guideline did not make a recommendation for or against the use of antioxidant supplements. However, it underscores that optimal nutrition is important during the pre-pregnancy period for the couple, but yet the effects of antioxidant supplements for males with specific male factor pathologies in couples with infertility are currently not known. What this means is that despite widespread use of antioxidant products globally, the evidence simply does not allow us to make a clinical recommendation, either for benefit or for harm. The trials are heterogeneous, frequently underpowered, and rarely report pregnancy or live birth. So the guideline promotes healthy nutrition, but it intentionally avoids endorsing supplements that lack proven efficacy. Next, please. So varicocele is the only male infertility condition for which moderate certainty evidence consistently show a benefit when the condition is clinical, I mean, when the varicocele is palpable during a physical examination and semen parameters are abnormal. So the guidelines recommendation reflect this. So for males with infertility and clinical varicocele, the guideline suggests surgical or radiological treatment over expectant management, which is a conditional recommendation with low certainty of evidence. For males with infertility undergoing treatment of varicocele, the guideline suggests using either surgical or radiological treatment. Again, a conditional recommendation, and now with very low certainty of evidence. So this part underscores that males with clinical varicocele and semen parameters that are outside the WHO reference ranges are more likely to benefit from receiving treatment compared to men with semen parameters within the reference ranges. And when selecting between surgical or radiological treatment, clinicians should consider feasibility, the availability of trained healthcare providers, and also patient preferences regarding the type of treatment procedure. So these recommendations apply to males with varicoceles in couples with infertility who are not undergoing treatment with ART. Next slide, please. So the next question is how best to perform varicocele treatment. So for males with infertility undergoing surgical treatment of varicocele, the guideline suggests using microscopic surgery rather than other surgical procedures, a conditional recommendation with very low certainty of evidence. For males with infertility undergoing non-microscopic surgical treatment of varicocele, the guideline suggests using either inguinal or retroperitoneal surgical procedures, again, a conditional recommendation with very low certainty of evidence. So the guideline underscores that subinguinal microsurgical procedures is very common for treating varicocele, while other surgical procedures, including non-microscopic approaches, and this is inguinal and retroperitoneal, and also laparoscopic methods for fixing the varicocele. In settings where the expertise to perform microscopic surgery is not available, other surgical techniques may be used, And again, these recommendations apply to males with varicocele in couples with infertility who are not undergoing treatment with ART. So in summary, concerning varicocele treatment, the guideline highlights that the benefit is seen in clinical varicocele and abnormal semen parameters. The choice between surgical and radiological correction depends on local expertise and patient preference. And for surgical repair, microsurgery is preferred, but other approaches are acceptable when resources or training are limited. Thank you very much.
Thank you. Professor Tansu, over to you.
Thank you very much. You see the flow of unexplained infertility treatment in this diagram. From the simplest to the most complex, from the cheapest to the most expensive, all with varying success rates. Let's have a closer look on them. Next, please. For couples with unexplained infertility, WHO suggests expectant management as the first-line treatment rather than unstimulated intrauterine insemination or ovarian stimulation with timed intercourse. Expected management includes providing advice on lifestyle, weight loss, and the most fertile days of the menstrual cycle and monitoring if the pregnancy will occur. However, no medical intervention is provided. The duration of expectant management was typically 3 to 6 months in studies informing this recommendation. Next, please. Second-line management for couples with unexplained infertility where expectant management has been unsuccessful, WHO suggests stimulated intrauterine insemination with either clomiphene straight or letrozole rather than with gonadotrophins. When selecting whether to use clomiphene straight or letrozole, consider the applicable national laws and regulations related to off-label use of letrozole. It is not yet clear how many stimulated IUI cycles are optimal. Studies informing this recommendation offered anywhere from 1 to 6 cycles, with more recent research typically suggesting 3 to 6 cycles. Next, please. Third-line management for couples with unexplained infertility where stimulated intrauterine insemination has been unsuccessful, WHO suggests in vitro fertilization without intracytoplasmic sperm injection, as there is no male factor in unexplained infertility. Thank you, Nandita. It's back to you.
Super. Thank you so much, professors, for your presentation. So till now, we've heard about the background, the methodology on developing the guideline. We heard about diagnosis of infertility, and we just heard about treatment for infertility. And all of that is found in this guideline. Again, we've shared the links in the chat. You can submit questions and answers using your Q&A box at the bottom of your screen. I'm now going to turn it over to Claudia Kordick to provide some remarks from a patient perspective. So Claudia, welcome, and you have the floor.
Thank you very much. Good afternoon to everyone joining this important launch. My name is Claudia Kordic, and I'm here on behalf of Fertility Europe, the pan-European organization bringing together more than 30 patient associations in the field of fertility and infertility. It has been an honor, but also a huge responsibility to contribute as one of the patient representatives in this development group for these guidelines. We often speak about numbers. We heard already it's 1 in 6 people worldwide experiencing infertility. In Europe, in some European countries, it's rather 1 in 5 people experiencing infertility. That means in Europe alone, around 25 million individuals. But behind these numbers are real people trying to enlarge families, people who far too often encounter stigma, silence, misinformation, and man-made barriers to fertility care. Access to fertility care remains deeply unequal across the world. In some regions, strong scientific guidance and guidelines, they really do exist, such as those developed by the European Society for Human Reproduction and Embryology, ASHRA, in Europe, or for the US, it's the American Society for Reproductive Medicine, as well as, of course, other professional societies around the world. But in many countries, there are neither national guidelines nor regional guidelines. There are no care pathways, no structured support for people living with involuntary childlessness. And this inequity directly affects people's lives and chances to build the families they hope for. And this is what makes these WHO global guidelines so important. For the first time, we have shared, really evidence-based, and also right-based global recommendations that any country in the world can adapt, regardless whether the country has already some guidelines in place or no guidelines at all. These guidelines clearly place fertility care within a much broader context, like we already heard, a universal health coverage. Fertility care is not a privilege, but it is an essential part of sexual and reproductive health, and this is strongly underlined by the existence of such global guidelines. Having 3 patient representatives in this working group, being from Uganda, the United States, and Europe, we brought very different backgrounds to this working group, shaped by cultural expectations, financial barriers, of course, legal constraints, and social norms. Regardless of differences, the human experience of infertility, and I speak as a former patient, is similar everywhere. Our responsibility in this process was to ensure that the realities are reflected somehow in those recommendations. From a patient's perspective, the value of these guidelines are very clear. The guidelines, they define essential diagnostics, by that reducing delays and unnecessary costs. They establish evidence-based treatments which are realistic and safe. The guidelines, they recognize psychosocial support as an integral part of fertility care. And the guidelines, which is very important to us, they position fertility care where it belongs, into human rights and non-discrimination. As the guidelines themselves state, fertility care, including prevention, diagnosis, and treatment, should be accessible to all who need it without stigma or discrimination. These guidelines will absolutely make infertility and fertility visible. They will confront or are confronting inequities and bring accountability to health systems. But they also open the door for earlier, clearer, and more accurate fertility information and awareness, something millions of people are really missing all over the world. Fertility awareness from an early age, it is a topic we in Fertility Europe, together with ASHRA, are already actively addressing. As patient organizations, we are here now ready for the implementation of those guidelines. This is where the real change happens, in clinics, in communities, in schools, in ministries of health, in governments. Lived experience must continue to shape the next steps, and we will try to ensure that no one who needs medical assistance in order to achieve pregnancy is left behind. To conclude, it has been an honor to contribute to this work from the very beginning with other patient representatives from Resolve in US and Joyce in Uganda. And together, we look forward to continue our collaboration with WHO as these guidelines really develop and progress into meaningful impact for people around the world. Thank you very much.
Thank you so much, Claudia, for your inspiring and moving remarks. And congratulations again to the Guideline Development Group for making sure that patient voices and advocates and lived experiences were reflected in the development of these important guidelines. We are now going to turn it over to the Vice Chair of the Guideline Development Group, Professor Cynthia Farker, who will present on some of the research gaps and future updates. So Cindy, I welcome you and turn the floor to you. Welcome.
Thank you. And I'd just like to echo my colleagues on the GDG in saying what an honour it has been to be involved in this important endeavour over several years. Next slide, please. So one of the things that, one of the outcomes of a guideline like this is that it has highlighted the deficiencies and limitations in the evidence, sometimes called research gaps. And this is really important for us because this is how we can lead to important changes, prioritizing new research. So the gaps that we've identified are here in this slide. You can see that there were deficiencies in that very few studies were coming from low and middle income countries. Very few studies on patient values, preferences and acceptabilities of the different treatments. Data on costs and cost effectiveness was often either not present or suboptimal. Very few studies about the feasibility of introducing new technologies in different settings, and limited evidence or importantly, few studies or many studies that did not report live birth, which we consider to be the most important outcome, and instead reporting biochemical and clinical pregnancy rates. And so this this means that it has affected the certainty of the evidence or the quality of the evidence. And you will have noted that as you've seen the recommendations coming through, that the certainty has frequently been low or very low, and that leads to many conditional recommendations and a few recommendations that we've classified as or described as strong. And so we need to think about that, turning to the future and how we can improve the research that's being done in this area. Next slide, please. So the future guideline scope and updates will be planned and will occur, but this guideline has well, we know the topics that have already been covered, but the topics that have not been addressed, we hope to cover in the future. And I just briefly mention prevention of OHSS, prevention of multiple pregnancy, and research, presenting research about add-ons. And so those are topics that we can consider in future updates of the guideline. So, so thank you very much, and those are my comments, and I'll hand on to James. Thank you.
Super. Thank you so much, Cindy. Before we go to James and our closing, I want to share one more video that we have that summarizes some of this work and the work that all of you have contributed to, and all of you online will take forward in your countries.
One in 6 people worldwide face infertility, yet it remains overlooked in health policies. Without national guidelines in many countries, fertility care remains inconsistent. The new guideline from WHO marks a crucial step towards equitable care for all. The guideline provides 40 evidence-based recommendations spanning infertility prevention, diagnosis, and treatment. Its aim is to help countries integrate fertility care into universal health coverage. It also maps a clear journey for evaluation and management through 10 essential steps, from initial consultation to diagnosis, treatment, and follow-up. Effective fertility care follows a set of good practices that should inform the management of infertility. "34 recommendations address the diagnosis and treatment of female, male, and unexplained causes of infertility. Prevention is emphasized, particularly through education on fertility, risks of infertility from untreated STIs, and the lifestyle factors that can play a role. Diagnosis should be systematic and cost-effective in identifying the cause of infertility. Treatment, whether pharmacological, surgical, or through assisted reproduction, should be adapted to suit the cause and context. By implementing these recommendations, countries can help people exercise their reproductive rights and achieve the family size they desire. Fertility care should be available, accessible, acceptable, and of good quality in all settings. It should also be respectful and tailored to individual preferences and needs. For effective implementation, health authorities need to create enabling policies, services, and financing. Success requires collaboration. Countries are encouraged to adapt recommendations locally using an inclusive process with all stakeholders. This first guideline covers key topics in prevention, diagnosis, and treatment, but gaps do remain. Future editions will expand their scope as more rigorous and inclusive research emerges. Everyone has a right to health. With this guideline, WHO supports countries in turning that right into reality, so people everywhere can access respectful, effective fertility care.
Super. Thank you for that, for allowing us to show that video that summarizes the guideline. And thank you all for staying online and joining us for this session. I'm now going to turn it over to Dr. James Chiari, Unit Head in Contraception and Fertility Care in the Department of Sexual, Reproductive, Maternal, Child, and Adolescent Health and Aging here at WHO. James, you have the floor. Welcome.
Yeah, thank you. Thank you, Nandita, and thank you, colleagues, for joining us today for this launch of the guidelines, and looking forward to continued interaction as we move them towards implementation. So I'll talk about the next steps and also give a vote of thanks. And in terms of where we move from this, I think developing guidelines has been, as the speakers have discussed, quite a long task, has been difficult and a lot of work. But the next steps are even more involving and probably more critical. We'll be disseminating these guidelines through multiple channels. I think you've seen that they are available online for download. They'll be being translated into various languages. I've seen questions on that. So moving forward, but already we do have translations of the summary of the guidelines in French and also in Spanish. We'll also be supporting the adaptation process through our WHO country offices and region offices, support with our partners, UNFPA, and other partners, the non-governmental organizations, patient and professional organizations. And really, we are also available for countries which may want to do national dissemination webinars like this one, which we've done for a global audience. Please do approach us, and we can be able to arrange this through our WHO country offices. We'll be developing quite a number of implementation tools to help the use of these guidelines. And of course, we'll continue monitoring the uptake and use of the guidelines, because we know guidelines are just as useful if they do actually lead to change in practice. And on the next slide, we've already gone through what the guidelines covers, and what we anticipate is that there will be a change in the practice in terms of prevention of infertility by providing early information on fertility and infertility, changes of practice in diagnosis so that this can be done promptly to identify the cause in both females and males, and also changes in practice in terms of the treatment so that this can be either provided or the clients can be referred for psychosocial support or for treatment as needed. This guideline provides a source for countries which can either adopt the guidelines as they are. They can also adapt them for their local context and use them to update their clinical guidance. For us to be really successful, we need to be collaborative. And particularly at the center of this will be the ministries of health, the professional societies, civil society, and importantly, the people and the communities that are affected by infertility. And next slide. As you download the guidelines, there are also quite a number of resources that are available. These are important resources because they kind of capture a summary of all the recommendations. And these charts can be good IEC materials. They can be good quick reference materials that can be printed and referenced quickly. We have one on female factor infertility, a diagnostic chart, on uterine cavity disorder, male factor infertility, unexplained treatment chart, PCOS treatment chart, and also the components of male medical history and physical examination, and the same for female. And for those of us who are always, as we should be, are interested in knowing what is the evidence, why are these recommendations made as they are, we do have web annexes that contain all the evidence profiles, and the summaries, as I've said, are available in multiple languages. So please do feel free to download these resources and use them as needed. And on the next slide, we do see other additional resources from WHO. As we are launching these guidelines, we are also simultaneously doing quite a number of peer-reviewed publications for our scientific audiences, and this will be available in Human Reproduction, in Fertility and Sterility Journal, in the Lancet Global Health, and other journals as outlined there. We also have the WHO Infertility Fact Sheet that is available on the WHO website in case you want to quickly know some of the facts about infertility. And also, many of the presenters have referenced the prevalence estimates that were launched a year or so ago. These are also available on the WHO website, and also other resources that are available on the WHO Infertility webpage. The link is provided there. Next, yeah, so it takes a lot of work. It really does take a village to have a product like this. There are many more people involved than those who I'm going to formally recognize and acknowledge. And please do, if anyone is not in this list, we do really, as WHO, appreciate the inputs and the efforts that various people have put to get this guideline to where we are. But the Guideline Development Group, which we abbreviate as the GDG, you've been hearing that term often, were about 30 very dedicated experts, multidisciplinary, regionally diverse, who formulated these recommendations. We really thank you for hundreds of meetings that you joined virtually, for your untiring efforts, and many of you in very different time frames. So those who woke up very early or stayed up very late, we really do appreciate your contribution to these WHO guidelines. The external review group that went through these guidelines, both the stakeholders that were people affected by infertility and the experts. They gave us a lot of input on review, and we have tried as much as possible to respond to those. We had a whole team that was conducting the systematic evidence review, and they did a great job to look at the evidence and to present it to us in a way that it could be utilized. We had a guideline methodologist who led us from the methodological aspects to ensure that this was aligned with WHO processes. Under the leadership of Dr. Gitao, many of us WHO staff and consultants worked on these guidelines over very many years, and I really thank you all for all the efforts. And the various stakeholders that we engaged with, the healthcare professionals, policymakers, professional societies, advocacy organizations, and even funding agencies that we engaged through this process. And finally, I would like to acknowledge the support from the World Health Organization itself and the Human Reproduction Program, who have provided the funds and also the systems and the abilities for us to develop these guidelines. And I think most of all, I thank you, the participants in this webinar, for your attention to us, and we'll be following up with you to ensure that these guidelines do actually get implemented. We've been able to have those who speak French and those who speak Spanish join us in this launch because of the efforts of our translators. And we really thank you, the interpreters, for such a good job during this launch. And with that, thank you very much. And I'll hand it over back to Nandita.
Super. Thank you, James. And thank you again to everyone, including the Guideline Development Group, all of the experts, patient advocates, and of course, our participants online. We do have a little bit of time for questions because we had allotted 1 hour and a half for the session, and I see there's a lot of engagement online, which is great. So for those of you online, keep the comments coming, share with us how you plan to use this guideline in your setting. And we look forward to following up with you after the session. We have several questions, and I'm going to just start with the first one, kind of a broader question to WHO. So I'll ask Gitao and James, apart from these guidelines, which are very exciting, what are some of the other key actions and efforts that WHO has put in place to address infertility?
Thank you, Nandita. So in 2000, I think there are a number of initiatives that we started, but although most of these have come in recent years, in 2009, 2010, we changed the way that infertility is defined from just calling it a condition to calling it a disease. And the reason that was made was so that we can assist member states who are wanting us to do so that infertility and fertility treatment can be included in health insurance benefit packages. That was in 2009. Between 2023, we published the estimates that showed that 1 in 6 people of reproductive age experience infertility in a lifetime. And that was an important publication which shows just how big the problem is, and there are no differences between world regions or the health, the economic status of a country. High-income countries and low-middle-income countries basically have very little difference in terms of prevalence. Between 2023 and 2024, we supported efforts that included fertility treatments, particularly clomiphene and letrozole and bromocriptine and I think bromocriptine within the essential medicines list. And this is important because the essential medicines list, WHO essential medicines list, form an example or backbone that can then be translated into countries. So those are some of the efforts that we've taken. And of course, the guideline has been the last effort that we are putting into place to make sure that we are increasing the visibility and the public understanding and awareness of infertility around the world. This, as the director said at the beginning, this is just the beginning. We want to continue putting efforts, but Also, as you have seen on the website, we published a fact sheet that is quite relevant to stakeholders, which provides basic facts around infertility, and we want to continue doing so as we move forward. We've got a couple of initiatives with some of the leading journals in the field, and I just want to thank Human Reproduction and Fertility and Sterility, because we want to enhance it as well, because we want to make sure that this information is also available for scientific audiences. Thank you, and back to you.
Wonderful. Thank you, Gitao. We have another question, and thank you for those who are staying online for the Q&A. We have another question about the methodology. And so I'm going to ask perhaps Cindy to see if you can respond, or I'll turn it over to anyone else in the GDG. If you could kind of share with us what were the most challenging methodological issues that you encountered as part of this process, given the complexity of this topic. So let me start with Cindy, and then I'll invite others to chime in. Welcome.
I think the hardest thing is where you don't have certainty about the evidence that you're looking at. So I mentioned that already about the very low and the low, and how the group had to navigate that. I think that is our challenge, is the quality of our research is lacking in many ways, and it's not just about randomized controlled trials, because the great thing about the grade system is it does allow you to have observational studies and you can upgrade, but we still really are lacking in that evidence, and I think lacking in planning for evidence in the future. So we've just identified gaps, and there've also been priority lists previously made, and we should be using those to plan future research instead of the slightly haphazard pet topics that that we focus on. I'm sure that Gitao's probably got more to say about some of those challenges than I have.
Thank you so much, Cindy. I think that you've made a very good summary. One of the points that we also, of course, ran into is not just the strength of the recommendations, but also the fact that there were a number of studies that were retracted, and we have clearly indicated the ways in which we were able to deal with retracted studies. It is something that is affecting not just this field, but scientific community as a whole, and we need to be much more vigilant about data fabrication, use of data that is not really true, that cannot be linked to individual participant data sets and so on. And so that's one thing that moving forward, we want to make sure that we strengthen a little bit more, and we will share on the link here and in the follow-up email a commentary on the ways in which we dealt with retraction of articles which has been published alongside a summary in the Human Reproduction Open, in the Human Reproduction Journal. Thanks. Back to you, Nandita.
Wonderful. Thank you. Our next question is around some of the prevention interventions that were mentioned. So I'm going to ask Jackie. The guideline addresses several issues around prevention and several interventions, but there are some areas that might not be included. So can you give us some insights into how you determined how to include the recommendations on prevention?
Yep. It's always a bit of an issue to choose among the many risk factors and which one can be reliably discussed. But essentially, the group focused on the areas or the issues where the evidence was strongest, where WHO already had some recommendations, such as smoking and STIs. And also where there was evidence that linked the risk factors to fertility, because sometimes the risk factors are discussed in a more generic way and they're assumed to have a link to fertility. In the future, obviously more risk factors will be considered. For example, genital tuberculosis, genital let's see if I can pronounce this, schistosomiasis, but also fertility preservation for people going through gonadotoxic therapies. So obviously there's more to come. Thank you.
Wonderful. Thank you so much, Jackie. And certainly a complex topic. And so the need to sort of really look at the quality of the evidence was really important. There's another question, a little bit more specific, asking conditions like endometriosis and fibroids were not included under female diagnosis and treatment. Are there plans to address some of these issues? And maybe for this question, I'll turn it over to our colleagues who are working on that, the experts on that part. For Bob, would you be able to weigh in on that?
Certainly, there will be future efforts. There were only so many topics that we could address, and we chose to address other topics now, but future guidelines will clearly address specific conditions that are common, the two most common clearly being endometriosis and fibroids.
Super. Gitao, do you want to weigh in, or anyone else from the GDG on some of the conditions that might have not been included in this guideline, like PCOS and others?
Thank you very much, Nandita. Yes, we do have quite a long list of the areas that the GDG felt were important, but could not be dealt with in this first iteration of the guideline. And it's a very long list indeed. You had to go through it, and we have included a graphic and a significant amount of text on that. But those relate to not just endometriosis and fibrosis, they also relate to the fact that for males, there was very limited guidance that we have provided. We need to provide more guidance in terms of more advanced tests, DNA fragmentation, and so on. We have issues around the use of additional add-ons that are added to IVF, which we want to look at the evidence, be very clear about the impact of those. We're very also interested to expand the guideline, the recommendations on PCOS, which, as Adam Barron has mentioned, it is much more than what we have been able to provide, including much more emphasis on lifestyle changes and what some of those the impact of potential interventions around PCOS might be. There is a lot more still that we can do in terms of making clear that the risk factors beyond just smoking and STI have an impact, including excessive use of alcohol and other risk factors. I have seen also a question that was related to environmental issues, heat stress, and so on. So those questions, we've also included them as part of future versions. We know that we are working in an environment where artificial intelligence is featuring a lot in terms of healthcare provision. So we'll be tracking some of these advances and making sure that we think about them for future recommendation and future editions of the guideline. Basically, this is a start, and we want to get feedback from everyone who's using these guidelines. We want to understand what you think the most important questions are. As the Vice Chair has mentioned, there's already been some efforts of prioritizing questions that should be addressed in the future, and we will be consulting those as well, whatever's been published. So there's a long list, and it's all listed in the guideline. And I'm sure that people will look at it and think, well, there's something else that's been left out, and we are committed to making sure that we continue engaging with everyone for the next version. Thank you.
Thank you, Gitao. And that's a wonderful way to close the session, recognizing that this was a large piece of work and is a start, and really looking to all of you online to share how you'll use the guideline, what are the gaps that still remain, and how can WHO and experts around the world continue to support fertility care that's equitable for everybody. So thank you to our panelists, to the Guideline Development Group, to all of the experts and patients, individuals that contributed to this guideline. Congratulations to all of you. And again, thank you to our interpreters for making the session available to those in French and Spanish. Just as a last closing, you can find more information on this guideline and many others on the WHO website, specifically the page on infertility. Again, we have the summaries available in several languages. We've put the links in the chat, and we will share them with all of you who registered online as well. So thank you again. Congratulations to everybody. And we look forward to seeing how these guidelines are used in your countries and in your work in the future. Thank you, and enjoy the rest of your days. Bye-bye.
Bye-bye. Thank you.
Bye.
Bye.
Bye.